get really excited to hear about how we can get what we deserve with our coding. So we'll get started now.
Great. Okay. Thanks so much. Thanks for having me. Uh, Hopefully my slides will play. You'll see what we're talking about. This is sometimes a little bit of a dry topic, CPT and HCPCS, but it's an important topic, especially if you have children and you want them to go to private college. So I'm going to go through a number of aspects of this. Here's my conflict slide. No particular conflicts related to CPT coding, unfortunately. Here's also a picture of a conflict. Can anyone identify this conflict?
It's not Harry Potter, is it?
Yeah. It is Harry Potter, but I feel like in an organization like this, people should be a little nerdier than that. Can we get a little more information? Right, that's like saying it's Star Wars.
You go with Deathly Hallows.
So here we are in the Goblet of Fire, right? You see Harry over here, right? You know that Cedric Diggory's body is over here, right? They're just in the graveyard in Little Hangleton after having won their competition simultaneously. Okay. Anyway, so coding. So no, not that kind of coding. We're talking about CPT and HCPCS codes. We're going to talk about what codes are, where they come from, and then we're going to review some codes in a handout. I'm sharing that handout. It was emailed to you, but I also shared a link to it in the chat just now. I'm going to speak about the codes. It may be helpful to you if you have access to that handout. Then we're going to do a little bit of coding ourselves. We'll kind of go through some cases. The best way to learn coding and learn about coding is to actually do some of it and get your hands proverbially dirty. So CPT and HCPCS codes. So CPT stands for Current Procedural Terminology. That's a registered trademark of the American Medical Association. And HCPCS stands for Healthcare Common Procedure Coding System, and that's owned by the Center for Medicare and Medicaid Services. In 1966, the AMA came out with procedural CPT codes as a research mechanism. They wanted to know what procedures were being performed in the United States. The committee reconvened 4 years later, and in 1970, CPT second edition came out, which included diagnostic and E&M codes. E&M refers to evaluation and management. That means your clinical visits, outpatient and inpatient settings. Momentum really picked up in 1977 with the fourth edition. CPT coding was never intended for anything other than documentation and research purposes, but the Center for Medicare and Medicaid Services in 1977 said, hey, we could use this for billing too. And so they created two parallel systems, CPT for physician billing and HCPCS for facility billing. In general, codes are parallel, but CPT is generally administered by the American Medical Association, and HCPCS is administered by CMS, the Center for Medicare and Medicaid Services. Since 1977, CPT has been updated annually. New updates follow the academic year cycle. They take effect on July 1st, generally. There's a lot of money in this, and not only for you and not only for the government, but it turns out for the AMA. In 2024, the CPT, which is about 700 pages, sold for $120. And sales of the CPT manual actually accounted for 53% of the AMA's budget. So thank you from the AMA for buying it. This is a busy slide, and the reason it's a busy slide is this is a busy process. So where do CPT codes come from? This is the American Medical Association CPT and RUC process. So first, where do CPT codes come from? They come from, well, anyone. They can come from professional society. Any professional society can propose a code change application. They can come from an individual. You can propose a code change application. And they can come from industry, and a lot of them do come from industry. And industry tries to partner either with individuals or professional societies to submit a code change application. Code change application can be to alter an existing code, or more commonly to create a new code. Now, when a code change application is submitted, it goes to the CPT editorial panel. Okay? This is a cabal of 21 members. They are physicians. They each serve a 5-year term and are eligible to serve 2 5-year terms. So most of them serve 10 years. It's a very time-consuming, unreimbursed process. And these 21 folks come from a variety of specialties. They meet 3 times a year, usually at small conference centers in godforsaken places. And because they come from 21 different medical specialties, they can't represent everybody's specialty. There are 96 society advisors. So each professional society in a recognized medical specialty, like interventional cardiology, has an advisor. So, for example, Sky has an advisor that meets with the CPT panel at each of these 3 meetings and reviews all the codes related to interventional cardiology and advises the CPT panel about them. For better or for worse, I am cursed to be the Sky advisor for the CPT panel. Now, the CPT panel does not currently have a cardiologist on it. There was a guy named Rob Piana, who's an adult congenital interventionalist at Vanderbilt, who served 10 years from 2013 to 2023, so he just rolled off. But right now, there's not a cardiologist on it. There is a vascular surgeon and there is an interventional radiologist, which sometimes is a blessing and sometimes is a curse because they know a lot about our stuff, but maybe a little knowledge is a little bit dangerous. In any event, the CPT panel can do 3 things. They can reject a proposal. Most proposals get rejected. Okay? Anything that is industry sponsored that doesn't have a professional society backing almost always gets rejected. Initially, they can approve a Category 3 code. Category 3 codes are research or documentation codes. So if a Category 3 code is approved, every time it's coded, the Center for Medicare and Medicaid Services doesn't pay for it, but the usage of that procedure is being documented. So for example, now we have active Category 3 codes for coronary drug-coated balloons. We have active Category 3 codes for renal denervation, right, where you can document that you're doing those things, but it turns out nobody's going to pay you a physician fee for doing them. Okay? Now, Category 3 codes can be tracked for several years, and they can provide evidence for review by the CPT panel to be advanced to a Category 1 code. They automatically sunset after 5 years if they're not advanced. Ultimately, the panel can approve a Category 1 code. Category 1 codes are generally what drive our reimbursement. They're sent to the RUC. The RUC is the Relative Value Scale Update Committee, RUC, which conducts a survey to establish value. Now, the way a survey works, the survey is sent by the professional society on behalf of the AMA to approximately 10% of the practitioners in that field. And it asks key questions about time, technical skill, and risk. So how long does it take to perform a procedure? How much skill or training does it take? And how dangerous is it, or how much risk is involved in that decision-making? Time is by a long shot the most important. The things that take longer get valued higher and get paid more. The RUC ultimately comes up with a number of relative value units. Okay? There's a relative value scale, and the number of relative value units is a recommendation from the RUC. That's then sent to CMS, the Center for Medicare and Medicaid Services, for approval, and about 90% of the time, they accept RUC recommendations, and CMS also assigns the parallel HCPCS codes. Okay. Next section. This is a little bit of a whirlwind, but we're going to talk about a couple of codes. I'm going to send that handout in the chat once more in case people don't have it. Copy. Okay, so if you have the handout either in the chat or there are a bunch of them back there, I've created this handout that lists codes for coronary, structural, peripheral, and evaluation and management coding. Okay? In the coronary space, a couple of pearls. So, first thing you generally do is administer sedation. We have a code, 99152, for moderate sedation, initial 15 minutes. Okay? Now, initial 15 minutes, that's an important point. Every time-based code requires you to spend half of that time at least to get credit for it. So to be able to code for doing something for 15 minutes, you need to spend at least 8 minutes doing it. Okay? If you spend 7 minutes, doesn't count. So if you do a right heart cath and you're really fast and you document a start and stop time that are less than 8 minutes apart, you can't code with sedation. Okay? Because you didn't spend half of the 15 minutes doing it. Okay? Now, that's initial 15 minutes. What about subsequent 15 minutes? So you can't double dip. So when you start the procedure, you're administering sedation and you're monitoring the patient. Once you start manipulating wires and catheters, you've converted from being the anesthesia provider to being the procedure operator. You can't be both at the same time. Okay? So you should keep monitoring the patient after the procedure begins, but the nurse is administering the sedation, you're the supervising provider, you're not able to bill. So there is a code, 99153, for subsequent 15 minutes. It's associated with facility reimbursement, but not with physician reimbursement. Okay, so you can bill as many 99153s as you want. That and a quarter will get you a gumball. Okay? Now, next thing I listed here, I put in bold the one that you use most, ultrasound-guided vascular access. Many people here, I think, are part of the Facebook generation. Some of the younger ones may be part of the Instagram generation. I don't see anybody who looks like they're part of the Snapchat generation. I do have a teenage daughter who is very much part of the Snapchat generation, and it terrifies me. If you don't, it didn't happen, right? If you say you used ultrasound, that's great. You need a picture in the permanent electronic medical record and to document that happened. Okay? Ultrasound-guided access, as you know, is something that sometimes is done and sometimes is not done. This is not a conversation about what is appropriate. This is a conversation about billing for it. Anything that is required for a procedure is typically bundled into the code. The goal of the code set is to be parsimonious. So, for example, there's no way to do a left heart cath without putting a catheter in the aorta. You can't bill separately for aortic catheter placement and left heart cath. It's presumed that somehow you got a catheter to the aorta. It's bundled. Okay? Ultrasound-guided access is an oddity in that it's bundled for all of the left heart, PCI, and right heart codes, but it is not bundled for the peripheral and structural codes and MCS codes. So if you use ultrasound-guided access for the right groin and you do a left heart cath, you cannot code 76937. But if you do ultrasound-guided access in the right groin to put in an impella and then do that left heart cath, now you can code for ultrasound-guided access. The vagaries. Okay. I'll comment on 93458 left heart and cores. So we have separate codes for coronary angiogram, that's 93454, and left heart and cores, 93458. How long does it take you to cross the aortic valve? Well, I'll tell you, it's worth 1.06 RVUs. So the difference between coronaries only and left heart and cores actually turns out to be around, at current reimbursement rates, $34. So if it's all the same to you, get an EDP, clinically useful information, and it's certainly worth that 1.06 RVUs. Okay. How many coronary arteries are there? How many coronaries are there, right? Some people have a ramus, some people don't have a ramus. Well, it turns out how many coronaries there are depends on how many procedures you're doing. So let me give you the following description. If you perform PCI stenting in the LAD, you can bill a code 92928, single vessel PCI. If you stent the LAD and the circ, you can now bill 92928, the same code, twice, right? Two totally separate credits. If you stent the LAD in the first diag, it's a branch. It's part of the LAD, 92928. If you stent the LAD and the first diag and the second diag, single vessel, 92928. If you stent the LAD, the first diag, the second diag, the third, fourth, fifth, sixth, and 17th diag, you've done single vessel PCI. So people come across a case, right, where there's a circ lesion, and then there's this high marginal, maybe it's a ramus. Is it a marginal or a ramus? It's a ramus, because if it's a marginal, you don't get paid to do it, and if it's a ramus, you do. Okay, I'm not saying you should falsify things, you should not. But if you're not sure whether it comes off the left main or the circ, it comes off the left main. Okay, good. On the structural codes here, I note TAVR percutaneous transfemoral 33361, and that's associated with 22.47 RVUs, which is quite a bit. Modifier 62 required. Split. What's that about? So I put the modifiers on the bottom of the peripheral page, the next page. There are lots of modifiers, but I'm going to mention a couple of key ones. Modifier 62 refers to a co-surgeon. You can use modifier 62 for a couple of procedures, a number of procedures, that are designated as co-operation. If you and a cardiac surgeon both scrub into a TAVR, you bill with modifier 62, and instead of billing 100% of the reimbursement for that procedure, you bill 62.5%, which is less, but you each bill 62.5%, so the institution as a whole takes in 125%. Now, you can't bill modifier 62 with somebody who's in your same specialty. Okay? So if you do left atrial appendage occlusion and you scrub with an electrophysiologist, you can bill modifier 62. If you scrub with another interventional cardiologist, you cannot bill modifier 62. So they have to be of a complementary or opposite specialty. Opposite is a loaded word. Different specialty. Okay. Modifier 52 is for reduced surfaces. That's for unsuccessful procedures, right? If you do CTOs, you can bill a lot of modifier 52s. Modifier 53 is for aborted procedures. Chest fire. Throwing it out there. If you do modifier 53, that's here. Always here. The wire always crosses from true lumen to true lumen. Okay. Modifier 53 is for complications. So you intended to CTO guys. Now, you intended to revascularize the CTO, but actually you perforated the LAD and terminated the procedure, right? You can bill with modifier 53. Different payers reimburse different percentages of the intended procedure with those modifiers, but usually it's more than 50%. Usually it's 50% or more. So usually there's decent reimbursement there. Modifier 80 is for an assistant surgeon. That's a situation where you say, look, this was a very complex procedure, required 2 attending physicians to scrub and participate. Usually you get 20% reimbursement for that, so you don't get a lot for being an assistant, but it's better than nothing. Okay. I'm not going to go through the peripheral codes in detail, but I do want to throw out a couple of key points in the peripheral codes. In general, in the periphery, there are these sets of codes where there are codes that begin with 3 and codes that begin with 7. 3 codes refer to I put a catheter there. 7 codes refer to I injected contrast and interpreted the angiogram. Right? So I put a catheter into the aorta, 36200. I took a thoracic aortogram and interpreted it, 75605. Now you can do a 3 code without a 7 code. So I measured the gradient across somebody's aortic subtotal occlusion, right? But I didn't inject contrast because they were in renal failure. Okay, so you did a 3 code, but not a 7 code there, and that's reasonable. There are codes that refer to first, second, and third order catheter placement, and then subsequently angiography. Now, the first order is not just something from Star Wars. It turns out the first order refers to crossing a bifurcation. So you get difficulty credit for crossing a bifurcation. And when I say crossing a bifurcation, I mean crossing it antegrade, right? You don't get credit for going from the common femoral artery into the external iliac. It's presumed well, it's not a bifurcation there. Into the common iliac, it's presumed you can manage to do it retrograde. It's the antegrade part that could be challenging. So if you're doing an up and over procedure, right, you get right femoral access, you're going up and over into the left external iliac, or to the left common iliac artery. The first bifurcation you're going to cross is the aortic bifurcation. So from right femoral access, you can say I did a first order catheterization if you enter the common iliac on the left. You've crossed 1 bifurcation. When you pass the internal iliac into the external iliac, that's second order angiography, right? You're in a second order vessel. You've managed to navigate another bifurcation. Now, coming from the external iliac to the common femoral, the inguinal ligament, there's no bifurcation, right? You don't get extra credit, external iliac versus common femoral, but when you cross either into the profunda or into the superficial femoral. Now that's third order angiography. You can go into as many below the knee or inframalleolar vessels as you want. There's no more credit beyond third order angiography. On the right side, though, let's say you're going antegrade. Of course, you should look in the mirror and make sure you've made the right decision to do that. But if you're going antegrade down the right leg, now your access site is in the right common femoral. So first order, right, your first bifurcation is the SFA or the profunda. That's first order on the ipsilateral side. Next bifurcation, let's say, is anterior tibial or TP trunk, right? So those will be second order, and the perineal and the posterior tibial will be your third order. So bifurcations get you credit because it requires you to do some work. I'm not going to go through the E&M codes now. There's a lot of information about them here. If people have questions about them, I'm happy to discuss them later. Feel free to email me or text me or call me. My information's on the handout. Because what I really want to go to is now to go through some cases. And I like to do this as a little bit of a competition. Okay? So indulge me if you will. I'm going to say, people, take one of these and take out a pen. If you don't have, if you're on Zoom, just pull out your handout. If you have a piece of paper to write on, that'd be great. We're going to go through 6 cases. Well, we might not get through all 6, but it doesn't really matter how many of the 6 we get through. The point is we're going to have a little coding exercise. Document your codes. If you feel up to it, we can trade papers, just like in 2nd grade, and we can review the coding. Who wins in life? Well, obviously, whoever gets the most RVUs, and that's the goal here, okay? People run to get pens, what's that? Everybody's got some sort of writing implement. Okay, here we go. Case number 1. Remember here, your focus is on the coding. Your focus is not on the clinical judgment. You may agree or disagree. We can discuss that later. This is an 80-year-old gentleman with coronary disease, status post prior PCI, presents with 2 hours of chest pain at rest. Okay, kind of left bundly. There's definitely some anteroseptal ST deviation. Okay. And angiogram will play. Okay. The angiogram shows that he has a world of pain. Okay. I may also note here that if the coronaries are on the epicardial surface of the heart and they're supposed to move with the heart, you can notice that the left coronary in general suggests there's dyskinesis in the left coronary distribution. So this guy's in trouble. So what do? You give him 0.5 midazolam and 25 of fentanyl for moderate sedation. You obtain right radial access, and you cross the aortic valve and measure an LVEDP of 25 millimeters of mercury. Now, clearly he's got a left main MI going on. You obtain ultrasound-guided right common femoral artery access. Here is a picture of the ultrasound that was used for guidance, and place an Impella CP. The LAD and first diagonal branch are wired. A co-registered IVUS is performed from the LAD into the left main. A single stent is deployed from the LAD into the left main, covering one diag and the circ. This is the angiographic result. Now the patient is in shock and has an Impella, so our shock team model is the patient should have a right heart cath placed. Okay, and here's Swan is placed by the right internal jugular vein. The cardiac output is 4 liters per minute, with the Impella producing 3.6 of those. Okay, so let's pause for a minute. What's it worth to you?
The fact that he's not coding is success.
I'm sorry?
I said the fact that the patient's not coding is a good start.
That is a good start. The patient is not coding, and the rest of us are coding.
But you lose.
Apparently that was lose 4 RVUs.
Yeah.
Do lose 4 RVUs, and it's worth mentioning. When we talk about CPR, obviously you do get credit for ACLS, but only if you do CPR, and that's an important point. If you have a patient who develops VF and you shock them immediately, nothing, because our code that we have, 92950, is a code specifically for cardiopulmonary resuscitation, which requires that you do chest compressions with an S on it. So you need to document that you did at least 2 chest compressions. 1 chest compression is inadequate, 2 chest compressions. Okay, and you can shock the patient as many times as you want, but you don't get credit for cardioversion except in an elective setting. Elective cardioversion for AFib is different. That's reimbursable. Okay. So if people want, they're welcome to trade papers, but I'm just going to kind of go through the coding of that scenario here. So first thing you did is you got moderate sedation, right? You administered moderate sedation to the patient, 0.25 RVUs. Now, left, right, and chords. So all of our left and right heart caths come in combinations. You don't get separate credit for doing a left heart cath, full stop, and a right heart cath. They have to be a combined code because there is some combined work, putting the patient on the table, preparing them. There's a combined code that is worth fewer RVUs than doing the 2 procedures in separate settings. Now, ultrasound-guided vascular access is eligible here because you placed an Impella, right? So ultrasound-guided vascular access for left heart cath or right heart cath, we said is not eligible, right? Because that is bundled. But for the Impella, it is, and you get 0.3 RVUs for that. Okay. Now, IVUS for an initial vessel. You IVUSed an initial vessel, and that's a good point because you IVUSed 2 vessels, but they're bundled because the left main IVUS is essentially a required part of an LAD IVUS, right? There's no way to put an IVUS catheter in the LAD without going through the left main. Okay, so that's a bundled piece. Okay. PCI for acute MI, so you get a little bit of extra credit, right? Instead of 92928, which is single vessel PCI, you do 92941 PCI acute MI. Okay? And then an arterial percutaneous ventricular assist device, that's the Impella. There's a separate code if it's an arteriovenous device, right? If you're putting in a tandem heart, for example. So all in all, you get 28.51 RVUs here. Okay. Now, 2 quick points on this. One, what's an RVU worth to you? On the bottom of your page, I think I put the 2024, right? Unit, what's an RVU worth this year? 33 bucks and change. Now, since 1992, there has been a physician fee schedule conversion factor for Medicare. So when Medicare wants to cut 3% of their budget across the board, all they have to do is reduce the conversion factor by 3%, which is what they're doing for next year. Right? So next year's conversion factor is jumping down to 34.65 cents, which means reimbursement for everything in the House of Medicine goes down. Okay? Since 1992, how much do you think the conversion factor has increased? Right? Inflation since 1992 has been, I don't know, 50%. I'll tell you, the 1992 conversion factor was $31.10, and next year we're going to be up to $32.34, right? So over time, we've lost a great deal of value here, and we've made up for that by doing a lot more in terms of efficiency, right? In 1992, wasn't an interventional cardiologist, but people did, a case or 2 a week, right? And now most of us do, 5 to 8 cases a day, right? And that's necessary to maintain the same level of reimbursement. Okay.
So Andy, can I ask you for this one? So why can't you, presumably the case didn't take 15 or 20 minutes, right? So shouldn't there be moderate, like the subsequent 15 minutes
for moderate sedation.
For moderate sedations as well?
But there's no physician reimbursement associated with them. So you can bill that's 99153
Yeah.
is subsequent 15 minutes,
Okay.
but there's no physician reimbursement because while you're doing the procedure, you can't bill as the anesthesia provider. You can only be one or the other. So if I can't imagine why this would happen, but if for some reason you have a colleague who's joined you who is sitting at the head of the bed providing anesthesia, he or she can be the anesthesia provider, but you can't double dip billing at the same moment for doing two separate procedures.
And earlier you mentioned that if you do an LAD PCI by itself, it's a
Mhm.
92928.
Mhm.
And if you do a circ, you said it's another 92928,
Correct.
not a 92
92929.
9299.
Yeah, so 92929 is a great point. 92929 is the code for side branches. It was introduced in the 2013 code set revision, and CMS did not accept any RVUs for it. They designed the code set so that they said, look, if 10% of your cases you do bifurcations, okay, so we'll increase the parent code for single vessel PCI by 10%, and that'll cover. So that sometimes you do bifurcations, sometimes you don't. It's the same code throughout. They did that because they wanted the code set to be simpler and because they wanted to incentivize simplicity. They don't want to incentivize people to intervene arbitrarily in small side branches that potentially aren't medically important. Now,
Can I ask a question? For this case, someone in shock, and you get an additional operator to join you, can I get a modifier on?
yeah, so you can get an assistant. Yeah, so that's a modifier 80. They'll usually depends on the payer, but generally for most Medicare and Medicare Advantage plans, you'll get 20% additional. That person will get 20%.
So who bills it? The person who comes to help?
Yeah, and they need to write a note. And their note doesn't need to be super detailed. They can say, I helped.
I was there.
The patient was critically ill, which is why it required a second person. You
What
need
did
to
they put as
justify.
the primary code in that setting?
They'll bill whatever they helped with.
I see.
But
Yeah,
Some
so
of
what
the
do you
shock
mean they'll bill
centers
whatever
is
they help?
routine
So
to
they'll
get two
bill what-
operators.
Like, so they would fill out, you know, if they were there from beginning to end, they would bill all these with the
for
modifier
the
80.
modifier 80. Exactly.
But then you're taking the other.
No.
Oh,
You're adding
You're adding
20%.
Okay.
Yeah, you're adding value.
So I guess this maybe a question for Sam, but like I feel as though we don't have, right? Like you can only bill you can't push that PCI of the main vessel twice, can you?
Yeah, you can
You
just
can
enter it
accept, you
again.
can accept it.
And then-
I don't think there's a way.
Or type the number.
Yeah, just type the number.
Interesting. Okay. I've done that exactly 0 times. So
It's
So
interesting. I mean, I asked our billing department to review our cases.
That's exactly what you do.
What we were billing, and they said that we're perfect. But I never used that same code twice. I've always used the additional one.
I mean, that's a lot of RVUs that.
Yeah.
The other thing is that, and maybe fewer RVUs, but I feel as though we have a separate button for Swan-Ganz catheter insertion. Is that like a standalone thing? Because in this, you put the right heart cath in. So like, if I had been doing this in real life, like I would have pushed the Swan-Ganz button instead of the right heart cath button.
Now for this, you gotta
Sure, I don't
click
think
the
it matters.
combine.
it's a combined.
It's a combined.
Yeah, right. You
Okay.
do left, right, and chorus here. Now, if you, we talked about how the vessels count separately for, like if you, what Rob said, if you do the LAD and the circ, it's 92928 twice. That's for PCI. It's not for IVUS or physiology. Okay, IVUS or OCT or IFR. IVUS, OCT, fair code. Exactly. And that's because the prep time for the IVUS, like if you use the Boston high definition IVUS and you spend all your time flushing it and advancing it, and then you kink it and then you need to take a new one. Right. All that time is spent once per catheter, not once per vessel. So the end result is if you're doing a multi-vessel IVUS, you'll bill IVUS initial vessel and IVUS subsequent vessel, but PCI initial vessel and PCI initial vessel, 2 vessels.
And then I guess the only other 2 points of clarification. So one is, so for like the modifiers, so you could probably build like a modifier 22 for this too, right? If they're,
It's a good point. So I didn't put modifier 22 here. Modifier 22 is procedural difficulty, right? You say something was particularly challenging.
yeah,
Almost no one these days reimburses modifier 22. It may make you feel better in your heart. It may relieve your angina. It may be nitro for you because you just spent, I don't know, 3 hours on a right heart cath in a patient with some sort of subclavian venous stenosis. But nobody's really going to pay you for modifier 22. I mean, very, very rarely. Some plans, some Cadillac plans will give you something for
Do
it.
we have information in that depth? Like, do we get a modified
I
to?
don't have that. I guess the other gaming piece of this is whether or not something's reimbursed by insurance versus
Yeah.
what's recognized as an RVU by our institution.
Yes.
So I'm pretty sure in our institute, and that affects the actual dollar per RVU rate is idiosyncratic to our overlords. So I would say that probably it's worth putting the 22
put it
in
in.
because I think it doesn't take a lot of
Doesn't
time
involve,
and it may help you with your individual RVU generation.
Okay, let's do another case. Okay. There's another coronary case. This is a 63-year-old male, has coronary disease, prior LAD PCI, presents with an NSTEMI, comes to the cath lab. You give him midazolam 1 milligram, fentanyl 50 micrograms, obtain right radial access, measure his LVEDP, and it is 19 millimeters of mercury. Yeah. Here's his right coronary. Let it play. You can see in the distal right coronary, there's some disease, and then there's quite a bit of disease as well in that kind of branching posterolateral, that second posterolateral up there that seems to go out all the way to the apex. Okay, so here is the left coronary. You can see the circ is really in pieces. And you can see that the LAD stent looks pretty good. Big cranial shock there. I think. The LAD stent looks good, but distal to the LAD stent, there is. That will play again. We'll play it again. Distal to the LAD stent, there is some area of disease, kind of moderate disease there. So, again, not about the management. I'll tell you what happened. First thing that happened was an IFR of the LAD. Okay. And the IFR was 0.90. Here's that image. So the decision was made to proceed with PCI. The right coronary was wired into the right posterolateral branch. Co-registered IVUS was performed of both the distal right coronary and the right posterolateral branch down that wire. 2 stents were placed, not overlapping, one in the distal right and one in the right posterolateral branch, not covering the PDA bifurcation there. So angiographically a happy ending. Nobody forgot about the circ. The circ was IVUSed down into the first marginal. The lesion was 48 millimeters long. Turns out 48 millimeter stents are available. So one was placed extending from the marginal across the AV groove circ into the proximal circ. Okay.
Injecting through the guideline.
I was injecting through a guideline. Play the image. Yeah.
I think for dissection, but sorry.
This is Fire 53.
We try not to get paid for that. Okay. So I'll give you a second to think about this.
Maybe coming up on this, but my question is the PCI for AMI and including it as high risk and STEMI. What
Yes.
defines high risk and STEMI?
It's a great point. So I don't have a slide on it, so I'll just say that right now. PCI for acute MI, the definition in the CPT manual is a patient who is brought emergently to the cardiac catheterization laboratory for an emergent procedure that is to treat a totally occluded or subtotally occluded vessel. Okay. So those are the 2 components. So the first thing is it has to be emergent. So if the patient comes in at 9 a.m. and you say, okay, add them on, we'll get them at the end of the day, that's not 92941, that is 92928, right? And if the vessel is totally occluded, so that's a key component because you're allowed to miss the diagnosis. So if you say, okay, we'll bring the patient at the end of the day, right? but then it turns out the patient has chest pain on a nitro drip at 160 all day, and you bring them in 5 hours later and find actually the distal LAD is occluded, you can still bill 92941. You can still bill it as an acute MI because it turns out you missed the diagnosis, right? Okay, so you're allowed to miss the diagnosis and still bill for the stenting. Okay. Okay, let's go through the coding on this one. So moderate sedation, right? You gave fentanyl midazolam, 0.25 RVUs for that. Left heart and cores. Okay. We measured an LVEDP, was 19, and then you shot a coronary angiogram. 5.6 RVUs for that. IFR initial vessel, right? We IFR'd the LAD. You get 1.38 RVUs for that. IVUS initial vessel, right? We IVUSed 2 vessels. So IVUS initial and IVUS subsequent. We IVUS to the right coronary and the circumflex. And then, this is the key point here, PCI with stent initial twice. Once for the right coronary intervention, once for the circ. Now in the right coronary, we stented the right coronary and separately stented the posterolateral branch, right? Doesn't matter. You can stent as many posterolateral branches as you want. They're all part of the right coronary system. You get to code for the right coronary once, and you get to code for the circ once. Questions on the coding for that case? Okay, I'm going to jump on to another case. This is an outpatient. 65-year-old gentleman, seems to be a theme, referred for anterior ischemia on a stress test. Bring him to the cath lab, midazolam 1 and fentanyl 50 for moderate sedation, ultrasound guided right radial access because it's really small. You can see it is present, it is accessed. And here's the angiogram, left heart. Yes, it's injecting through a guideliner. And you can see that he's got pretty significant disease there of the LAD at the bifurcation of the first diagonal branch and then disease of that diagonal branch itself.
You didn't cross the valve in this one?
No, we did not cross the valve. So, wire the LAD, wire the diag. Co-registered IVUS of the LAD and the diag. Okay, here are those IVUS images. Stented into the diag, or stented the diag rather into the LAD. The stent was underexpanded, as you can see here. Was not appreciated on IVUS, maybe, who knows, the degree of calcification. The stent did not expand, and a shockwave balloon was taken to, after the fact, expanded. Stented in the LAD, here you can see a double kiss crush, stented in the LAD across the diagosteum, and then here's the angiogram. The LAD and diag look better. Not a lot of procedurizing. How do you code it? I just got a double kiss crush. So, in interest of time, I'm just going to keep going. And I'm going to tell you how you code it. Moderate sedation. I think everybody recognized that, right? You administered moderate sedation. Cores only, as Rob pointed out. There's no LVEDP. If you don't document an LVEDP, you can't bill for left heart cath. Parenthetically, that's not entirely true. If you document an LV gram, you can bill for left heart cath, even if you don't record the pressure. So it's one or both, LV gram or LVEDP. Okay. IVUS initial vessel, right? Remember, the LAD and its branches are all part of a family. So there was the IVUS into the diag and IVUS into the LAD, but you can't bill for them separately. A coronary stent single vessel, PCI single vessel, right? 10.96 RVUs for 92928. Double kiss crush in a single vessel. This is not a left main bifurcation. This is not 2 vessels. This is single vessel. The LAD is 1 vessel, right? And then we do get an add-on 92972 for the IVL for the shockwave catheter. Now, I'd like to point out this is 20.52 RVUs. This is half of what the previous procedures billed. Okay? This procedure very much took longer than the previous ones, right? The double kiss crush is a long procedure, right? But that's the vagaries of the coding system. Okay. Okay. This, I'm moving out of the coronary realm now.
Yeah, I'll be there.
I've had trouble with this video, so I'll see if it plays or not. No,
Okay.
so that's fine. This is a 70-year-old man who presented with severe mitral regurgitation. He had prolapse of the A2 scallop, right, the anterior leaflet. He had a balloon pump and a swan that were placed in the CCU. And now he's coming to the cath lab for procedure. This procedure is going to be percutaneous mitral valve repair. He receives general anesthesia. And this procedure is scrubbed by an interventional cardiologist and a cardiac surgeon together. The interventional cardiologist obtains ultrasound-guided right femoral venous access. And here's the picture of that. And then transeptal left atrial access. An M-tier is performed with 2 microcups. So I'm going to pause for a second again and ask, how do you code this procedure?
M-tier is not required at 62.
M-tier is not required at 62. M-tier is an optional. Yes. So the only required 62 that affects us is TAVR, right? And that's a political thing. Every time somebody suggests that an interventional cardiologist could do TAVR alone, the surgeons remind us that a surgeon could do TAVR alone too. And it turns out that, well, I'll go there since we're on that subject. Vascular surgeons, as they've begun to do many endovascular procedures, argue that they offer a complete picture, that they can do open and endovascular procedures. And that competes significantly with those of us who only do endovascular procedures. If a cardiac surgeon can do TAVR alone, they can do open SAVR and TAVR alone. Why would you ever come to a cardiologist when you can go to a surgeon who can do whatever you need? Obviously, we outnumber them by a long shot, but I think most of us feel that if the 62 modifier requirement were to go away, it's the cardiologists who would lose out, not the surgeons. Disagree. So it remains to be seen. It may happen, it may not. Okay, I'm going to jump back into this M-tier case. So ultrasound guidance for vascular access, right? This is not a coronary case, or there's a non-coronary procedure being performed, so you can bill 76937 and get 0.3 RVUs for your ultrasound guided access. M-tier initial device, right? And that's 33418, but you did it with the surgeon, right? And so you've got to put in the modifier 62 there, you share it, you get 62.5% of the credit there. And then M-tier additional device, because there were 2 clips placed. Obviously, you're using a new clip delivery system, but the same steerable guide catheter. And so you, for an additional device, you get a lot less, right? Comparing 32 RVUs to essentially 8 RVUs for the additional device. And again, with modifier 62. Okay.
That's a question, Andy. Do you
Sure.
do ultrasound guidance for access for the bill for your LAO?
Yes.
Never done
Yeah.
Yeah.
It's a great question because here you're about to see LAAO. This is an LAAO case. Parenthetically, I'm just going to throw out. People sometimes ask me, what's the procedure you did the most, or you do the most, and what's the procedure that generates the most RVUs for you? So I'm just going to throw out, if you want to guess. For me personally, in my practice, I want to guess what the procedure that I did the most of last year.
LAO.
So the
Moderate sedation.
Moderate sedation's always my number.
So here we go. So the thing I did, the moderate sedation is number 2. The cath lab procedure I did the most of was PCI. I did 148 PCIs last year and 104 LAAOs. But the procedure I billed the most for last year by a long shot was EKGs. Okay. Last year I read 20,001 EKGs, okay, which is 3,400 RVUs. Okay. So you get 0.17 RVUs per EKG. Parenthetically, that was a change in 2020. It used to be that you got 0.24 RVUs per EKG. And then somebody caught wind of the fact that actually AI was reading your EKGs and you were just clicking accept, accept, accept. And so the reimbursement was dropped from 0.24 to 0.17. The American College of Radiology is leading a work group regarding how AI should affect coding, because radiology is at high risk of being replaced by AI, right? We know AI can read an EKG. There are some pretty good algorithms to have AI read an echo. We know in the cath lab when we use, angi-FFR or VFFR that turns out AI can read an angiogram, right? AI can do a lot of things, and the question is, how do we get billed as being the taskmasters running the AI and overreading it? How much overreading is necessary? How much time does a procedure take if AI does it and we're just overreading, right? So, so the number one procedure I did last year was EKGs by a long shot, followed by moderate sedation. I think Chris said that. And then number three for me was inpatient subsequent day visit, right? So, I do, I think 4 weeks of CCU service a year, patients there multiple days, subsequent day visit is number three for me. Okay, here we go. Case number 5, this is a 74-year-old gentleman, paroxysmal AFib, has a GI bleed, and wants to get off his apixaban, presents for left atrial appendage occlusion. He receives midazolam 1 and fentanyl 50 micrograms, ultrasound-guided right femoral venous access, and here's the picture to prove it. Here you can see, this is the 3D ICE guidance. Here you can see the ICE catheter and the, this is a Watchman case. You see the Watchman, demonstrated placement, looks okay. How do you code that? I'll tell you here, there are 4 things you can get credit for. I'm going to jump right to them, and they are moderate sedation, ultrasound-guided access, left atrial appendage occlusion, and the point here is 14 RVUs. If you scrub with an electrophysiologist, you may benefit from his or her expertise, but you'll bill a modifier 62 there, right? If you scrub with another interventional cardiologist, you may benefit from his or her expertise. You will not bill a modifier. Only one of you can bill for that. And then the ICE guidance. Now, ICE, see, 93662 has a plus next to it. ICE is an add-on code. Add-on codes are special codes that have a list of primary codes with which they can be associated. So let's say you have a patient who has a concern for endocarditis, and they've got bad COPD. You don't want to intubate them. You don't want to do a TE. You're concerned. You want to just use an ICE catheter to look for endocarditis. Can you bill 93662 for standalone ICE? And the answer is no. That is free. You're doing that service for free because ICE can only be billed as an add-on to certain other procedures, right? There's a list of procedures which allow ICE as an add-on, and they include the things you'd expect, right? Septal interventions, ASD, PFO, left atrial appendage occlusion, AFib ablation. You can't do you can do standalone ICE, you can do whatever the heck you want, but you can't bill for a physician reimbursement for standalone ICE. Okay. I'm going to really quickly mention a peripheral case. This is not a real case. This is a made-up case. For those who know, I haven't done a peripheral in many years. But we're going to give you a 63-year-old claudicant, tobacco-dependent, gets moderate sedation and right femoral access. Pigtail catheter placed from the right femoral into the aorta, distal aortogram with bilateral runoff. Let's do a lot, right? In peripheral cases, often we balloon and stent in a lot of vessels, and there are a lot of vessels in the periphery. So we go up and over with a 45-centimeter sheath, advance it into the left popliteal artery, take an angiogram, and see there is a stenosis, treat that with PTA followed by DCB. Below the knee, the runoff looks bad, okay? Right, so we have 0 complete vessel runoff. A stent is placed into the perineal artery, and POBA is performed into the anterior tibial artery, leaving only the posterior tibia occluded. Okay. Happy result there. Now, we've done a lot of procedurizing here, right? In the periphery, you have the advantage that there are lots of different named arteries and lots of bifurcations. The reason I show this case is to show how many RVUs you can generate if you do peripheral intervention. And, coding structures change, but at present, you get the moderate sedation, you get ultrasound-guided vascular access, because this is not a coronary or right heart case. you get the abdominal aortogram floor extremity runoff. We've done a third order catheterization, right? The popliteal artery, we showed an angiogram with a catheter seen on the screen, and that's a good point. You have to have an image that shows your catheter in the third order vessel, right? So that's a third order catheterization. Okay. Then we did a FemPop PTA, that's 37224. It happens to be a drug-coated balloon case, right? But you don't get a ton of credit for that, right? It is a tibial perineal PTA with stent and a tibial perineal PTA in two separate peripheral vessels. And together that gets you 41.64 RBUs, so more than any other case we've discussed. Now, it's a complex case. It took a long time, but it's worth pointing out that the number of RBUs here is quite high. Questions? Okay.
GC modifier.
In the interest of time,
Andy, can I ask you one question? It's John.
I'm thinking about that. Okay. Yes, John.
If let's say you plan to do a mitral clip, you get access, but you can't get your transeptal for some reason or some other one. To what level do you bill that? Do you actually bill it fully as a clip, or if you're like you planned a CTO, but your access goes awry, do you bill it as a CTO? How do you decide that?
It's a great point. So you bill based on the stage to which you advance. So, for example, if you, in your mitral clip, weren't able to get the transeptal you wanted, measure a right heart pressure, you can bill it as a right heart cath. But even though the intended procedure was mitral clip, because you didn't get to the point of accessing the mitral valve with a steerable guide catheter, it's not billable as a mitral clip. Often, people talk in those cases specifically about measuring the right heart pressure on the way in and the left atrial pressure as well, because if worst comes to worst, you can bill it as a left and right heart cath because you've measured the left heart pressure and the right heart pressure. Yeah. Okay, so we can crown the monarchs of coding. Whoever got the most RVUs in this case, it's sort of a silly game, but as we know, this is a major feature of our professional lives right now. It's 8:32 and people have clinical work to do. I'm on call today, so I need to start driving north. But here as a closing slide, here are two of my coding assistants. I put my cell phone number and my personal email at the bottom. I'm always happy to discuss this stuff. I'm moderately excited about it. So feel free to text or call or email